Now, Francesca, you were presenting a matched, adjusted, sort of indirect comparison of momelotinib to other therapies in RUX-exposed patients.
Yes,
Can you tell us more about that?
right. Yes, because we started from one idea that is very difficult to select a second-line therapy once ruxolitinib has failed. So we know that ruxolitinib is a good drug, but 50 to 70% of the patient will finally discontinue the drug. And the prognosis after discontinuation is really poor, with an overall survival coming between 6 and 12, 18 months. So there is an important need, a clinical need, a unmet clinical need in how to select the best strategy for these patients who fail ruxolitinib. So we can base our decision on the target. I want to improve the spleen, I want to improve the symptoms. I have a very anemic or thrombocytopenic patient, but I can also decide to try to improve the overall survival. And to try to provide some more data on that, we actually made an indirect comparison, as you said, comparing the overall survival data from the simplified trials, the registrative trials of momelotinib in second line after ruxolitinib failure, and we compared the overall survival data with what we got from the RUX and NAF Italian study. From a patient who failed ruxolitinib and underwent other treatments, so VAT excluding momelotinib. And to match this population, we performed a couple of models or statistical models in order to have comparable populations, and we then compared the survival outcome. And in all the models we developed, we clearly observed the benefit for momelotinib treatment compared to any VAT, including other investigational agents. And also what is, I think, very important due to the approval characteristics of momelotinib, which includes not only anemic patients, so we also performed this model only based on patients with hemoglobin below 10 at the discontinuation of ruxolitinib. And also with this model, it was confirmed a survival benefit for momelotinib compared to VAT. So I believe that this is a kind of more data that can really increase our ability to select the best treatment strategy for our patients.
Absolutely. And Andrew, you've looked at your experience with PAC and momelotinib. Tell us more about that.
Yeah, so we're in a world we talked about with 4 JAK inhibitors, right? And so now we got to figure out where exactly we can use. Unfortunately, we don't have direct comparisons, aside from Simplify 1, which looked at Rux versus momelotinib, but we really don't know. And I think the 2 agents where we have a lot of overlap from an efficacy standpoint is momelotinib and pacritinib, right? Both of these agents can be used in patients that have cytopenias, low platelets, anemia. Certainly they have their niches, right? Pacritinib approved for low platelets, momelotinib approved for anemia, but we know that they have similar kind of targets, right? And similar activity. Pacritinib inhibits ACVR1. There's a lot of data suggesting it help with anemia. Momelotinib can be used in low platelets, but exactly where should we use this? So we started collecting our data on patients that have been treated with pacritinib and momelotinib. We've gotten 50 patients that have been treated at our center with one of those agents, and we really started to compare, first of all, what are the demographics of those patients? Because while we want to know what the anemia benefit is, I think that's probably the biggest thing, is we want to know which one's better at improving anemia. I don't think we're going to see that clearly, because I think the 2 different groups of patients are receiving them. And we saw that. What we saw really quickly is that patients with pacritinib, as expected, who have lower platelets, they often had similar times of disease leading up to this momelotinib, maybe a little bit longer disease course, which I think at first we thought, well, they're later in the disease, but actually I think they have better disease and have been living with it for longer and just have anemia. And so I think we're starting to kind of tease that out. We did see hemoglobin improvements with both agents, pacritinib and momelotinib. We saw that pacritinib patients really were on pacritinib for a very short period of time. Median time on therapy around 2 to 3 months. Momelotinib more than that. And I think that goes to the fact that these pacritinib patients oftentimes are very sick patients, right? They've had the disease for a while, platelets have dropped. This is kind of a last gasp effort oftentimes. So we shouldn't expect the same response that we see in maybe comparable momelotinib patients. One other intriguing thing I thought we saw, and it was with momelotinib, was, I think that there's maybe a kind of discrepancy on what our expectations may be with momelotinib when it's given in practice. And I saw this in the community some, which is patients, our physicians will say, I started momelotinib in my patient, but they didn't get any improvement in their hemoglobin whatsoever, right? They felt fine, the spleen did fine, but their hemoglobin didn't go up as much as I thought it would. And they hadn't been on previous ruxolitinib. And one of the things I think is while momelotinib can be used in anemic patients, it doesn't always raise the hemoglobin level. And so one of the things we looked at is what was the change in hemoglobin in patients who were coming off Rux on momelotinib versus those who were just starting on momelotinib, who hadn't been on, or who maybe been off Rux for 6 months or so. And certainly the improvement in hemoglobin is much more stark in those patients that are switching directly from Rux to momelotinib.
I see.
And that's what we see in Simplify-1, right? So I think when you go back to Simplify-1, frontline treatment, you see patients in a largely non-anemic population. Patients starting on momelotinib stabilize their hemoglobin for 24 weeks. It stays relatively the same. Patients start on Rux, it drops, and then it kind of incompletely recovers. And in 24 weeks, they switch back to momelotinib, and it comes back up to baseline. And I think that's what we're showing kind of in a real world setting.
So it's both coming off of Rux and the effect of that, and the ACVR1 story with the momelotinib.
I think it's a little bit of both. And what I would encourage community folks is that just because you don't see an improvement in hemoglobin when you start that, the benefit is being able to fully dose something, get spleen and symptom responses, and not hurt the hemoglobin in one sense as well. And so I think there's benefit to both of those things. And we aim to kind of further grow this cohort of patients and really start to look at hundreds of patients treated in the real world to get a better sense of exactly how comparable these agents are.
And to underscore your point, in the front line, you're going to get better spleen and symptom responses, and perhaps that's where it belongs and needs to be used more.